This is maybe a little bit related, but you're a clinical anatomist. So I am going to put forward a very practical question, which is kind of based on some of the buzzwords that are moving around today. Now, when you look at the lumbar spine and the thoracic spine, you have a superior causto-transverse ligament in the thoracic region, which is in the intertransverse plane. It is attached between the neck of the ribs and to the lower border of the transverse process. It has two slips. I also read that the superior causto-transverse ligament is non-existent at the transition zone, which is like T11, 12. So I like to hear your comments on that, one. Two is, what replaces the superior causto-transverse ligament in the lumbar region at the intertransverse plane?
Okay, first of all, the changing is absolutely really dramatic in the area what you suggested or just mentioned. That's correct, but that's easy to explain. You get the frontal position of the cervical joint areas in the thoracic part, and then it has to change to a sagittal plane, which means you get a more or less shift of the planes in the cervical joint. And therefore, it's also a change of these processes. So you get over here at T11 and T12 already the sagittally, especially in the T12 section, the sagittally positioned vertebra, and therefore a change of these processes to a more or less degeneration of the transverse process and then the costal process, which is more or less then developed. So the causto-transversal ligament is lost. This is something which is important, and it's changing to this mammallo-accessorial ligament. And therefore, the position of the medial branch is also changing, because it's not like in the thoracic spine, you get this constant course in the groove and in between the cervical joints, but more or less a little bit more lateral course. And this is something what we dissected, and we will publish hopefully next year. It was dissected by a student who, this was his thesis, and he dissected, I think, more than 25 spines in all the different areas. So this, especially the area of T12, T10 to T12. So the course is changing, and also, unfortunately, a little bit different to the thoracic spine and also the lumbar spine itself. So because of the adaptation of the position of the articular processes.
Thank you, George.
Just a moment. Second, is there a what about the causto-transversal ligament in the lumbar spine, as you asked as a second question? You get the membrane in between, so this is lost. The ligament does not exist, and therefore you get a huge gap, which means you might be in the area of the dorsal branch, which is piercing this foramen. You get a better flow ventrally. But nevertheless, if you really want to reach the lumbar plexus, for example, you have to advance the needle much more. You cannot go with a huge spread ventrally if you just say, okay, I want to be dorsal to this membrane, to the intertransversal ligament.
Okay, thank you, George. That explains some of it. But I have a little extension to that same concept. Is that today the erector spinae plane block that you may be aware of is an injection deep to the erector spinae plane block is making a lot of news about its application from the cervical region to the sacral region, and an injection deep to the erector spinae produces efficacy for pain relief, etc. Now, my question to you is, we don't have an exact mechanism of action today, although many cadaver studies, anatomical, radiological studies have been done. So the question to you is, if you look at the plane that is defined as the erector spinae plane, it is an intermuscular plane. And there are many intramuscular planes in the lumbar region in relation to all the lumbar paravertebral muscles, and they eventually open into the paravertebral space. They are connected. These intramuscular fatty compartments are somehow connected to the paravertebral and the epidural space. So if you were to make a large volume injection in the erector spinae plane, do you think the local anesthetic can make its way to the epidural space?
In the lumbar region, it might do so, because you get more or less not the small foramen, and also not, let's say it like that, the dense connective tissue layers in the foramen itself. You get more space. But I think that this is what I really believe concerning my dissections. You will not have a constant spread ventrally. So you cannot be assured that it will spread all the time. And that's the same with a so-called erector spinae block, which is underneath the erector spinae muscle. There is a misinterpretation about this muscle. It is strongly believed that this is an entire muscle and you get a wonderful plane underneath. This is incorrect. As you already said, it's an intramuscular injection because you inject into an area where there are so many muscular fibers inserting at the transverse process in the thoracic spine, which means you get a three-dimensional network of this muscle, and this is something what you cannot preview then, eventual spread. This is impossible. So what you really get is a dorsal branch block, that's perfect, but you do not get the constant spread ventrally. And this is all of the already existing publications confirm this. Even if you go intertransversally, you are still in the wrong plane. You have to go deep to it. You have to go into the paravertebral area. That's the paravertebral block. In the lumbar spine, it might be changed by the space you get. But I've never performed blocks. I just have performed blocks for the cervical joint with different methods. Mm-hmm. And what we found is that if you get really close to the cervical joint and be more laterally to the joint area, so in between the costal process and the articular process, you get a wonderful spread and an efficient block. But if you go medially, for example, and say, okay, you get 2 milliliters and then it will spread, no way. It's really prohibited. And this is something which is caused by the, again, three-dimensional network of this muscle, unfortunately.
Thank you, George. Since there are no questions, I have a question for you, Shankar. Are you ready?
Sure. Yes.
Right, sir. Yes. You allude to the fact that these paravertebral, or, even when you do medial branch facet injection in the cervical region, this area is laden with many vessels, particularly periforaminal vessels, small vessels. So first question to you is, would you recommend listeners to this webinar to perform these injections without subtraction, fluoroscopic angiography, as just an ultrasound guided periforaminal injection? Or would you recommend they should also be doing fluoroscopy with the contrast injection?
I'm glad you asked that question, Manoj. It's so good to see you and hear your voice after such a long time. I just replied to get to your question.
Yeah.
Yes and no. The question that they asked was, can we do cervical epidurals with ultrasound guidance? Yes, we can. But should we? Probably not. Because of what you rightly mentioned, we use digital subtraction angiography just to make sure that we are not injecting anywhere into the vessels. Now, typically we inject at the level of T12 or C8T1 for cervical epidurals. And we hope that it will spread higher. We try not to go anywhere above C7. When it comes to the selective nerve root blocks or other injections, I'm very comfortable using non-particulate steroid injections around this area because I plan my trajectory. I make sure that I'm able to pick up any vessels, including use of power Doppler in case it's a low flow state or whatever. So far, knock on wood, I haven't had any complications injecting around the neck, except for one, which was earlier on in my career. Yes.
Now, the question is, if a clinician is taking all measures and inadvertently injects some particulate steroid, however, it be a little amount before they realize it's been injected intravascularly, firstly, what are the consequences to the patient? And are there any things that you can do to mitigate any presumed problems that the patient may have?
Excellent question. So this is again based on my personal experience.
Of course.
What happens here is, despite the best precautions, accidents do happen. But following a safety protocol is very, very important. Never, ever inject particulate steroids anywhere above the lumbar spine. In fact, I would even go to the extent of saying no particulate steroids above the level of L2 because you're approaching the end of the spinal cord. Now, if at all you were to inject a non-particulate steroid, and stressing the word non-particulate steroid, accidentally into a cervical artery, not a vein, but into a cervical artery, all that we need is 0.25 to 0.3 ml of lidocaine to cause a seizure, or even to have some type of cloudiness to your brain. That is felt by the patient right away and says, "Doc, I'm feeling strange. Something is happening," or "my ears are ringing." The moment that happens, we have to have resuscitative equipment in the procedure suite available right away. So right now, what we have is a full-fledged anesthesia machine right next to my fluoro and ultrasound machine. So that is very, very important, just to manage the airway, as well as to make sure that you don't have a complication secondary to that. That is what I have found so far. But more importantly, what happens is not planning the trajectory and puncturing through vessels and nerves as you approach your target, because we have blinders on when it comes to doing a stellate ganglion or selective nerve root block and say, okay, I'm seeing the carotid artery, I'm seeing the longus colli, and I'm going straight there. No, that's the wrong approach. I think it is very, very important that we understand the entire topography and plan our injection before doing any needling in that area.
I think that's very well said. And anybody tuning in to think that these procedures in the neck are simple is probably naive, or may I say, ignorant about the anatomy. So one has to be totally conversant with many of the details of this before we venture into providing injections and pain therapy. So that is the disclaimer of this course. Now, thank you, George. And thank you, Shankar. It's been wonderful. I'm not saying you're no longer needed. It is just that we are coming to a short break to give everybody a little bit of a respite. Christine, you can still hang on and see if we can encourage some people in the audience. Hello there, come on.
Actually, there is a boost of questions in the Q&A box, which I think Dr. Virgo has answered some already.
Okay, that's okay, that's fine. But anyway, now I think we are coming to the break. So for those of you who are logged in, don't go away. This is just to give you some time so that you can have your favorite beverage, whatever it may be, wherever you are, and come and join us back in 15 minutes.